Good morning, everyone. I'm Dr. Towhidul Islam, MD in Clinical Oncology, representing Kulmitola General Hospital. First of all, I would like to thank Bangladesh International Cancer Congress Oncology Club for giving me the opportunity to present in this prestigious session. Today, I will be presenting our real-world multi-center retrospective study evaluating the survival outcomes with generic Osimertinib in advanced non-small cell lung cancer in Bangladesh. This study explores the clinical outcomes and compares them with major global trials. Globally, lung cancer remains the leading cancer and causes of cancer-related deaths. And most of the cancers, lung cancers, are diagnosed in stage 3 and 4. Third generation EGFR tyrosine kinase inhibitor like Osimertinib have become the preferred first-line therapy for EGFR mutated non-small cell lung cancer, particularly for those with CNS metastasis. And evidences were established in FLORA, FLORA2, and AURA3 trials. Tagrisso, the branded Osimertinib, is highly effective but extremely expensive. This high cost creates a major access barrier in low and middle income countries. As a result, both patients and treatment centers in Bangladesh often rely on locally produced generic or branded versions. As you can see, for 30 tablets of the research molecule Tagrisso, one has to pay $10,422 for 30 tablets. And if we convert it in the BDT, it is about 42,316 per tablet. That is 12,69,509 taka for 30 tablets doses. But in comparison, the local brand tablet per unit cost is 280 taka and 8,400 for 30 tablet doses. This led to concerns in other countries regarding the quality of Osimertinib available in Bangladesh. We have done a retrospective trial to evaluate the efficacy of local sourced Osimertinib in comparison to the results of existing trials on the research grade Tagrisso. Although the population, treatment standards, and statistical methods are not robust. This study included 97 patients with untreated metastatic non-squamous lung cancer harboring EGFR mutation, exon 19 and L858R mutations. It was a retrospective analysis across government and private centers with written informed consent obtained. The primary endpoint was progression-free survival and secondary endpoint was overall survival. Patients were followed every 3 months by physical and telephonic review, and data were analyzed using descriptive studies and Kaplan-Meier survival analysis. This slide summarizes the demographic features of patients across our study and the key Osimertinib trials. As you see, the median age in our trial was slightly younger, and women were the majority across all the trials, including ours, reflecting the higher prevalence of EGFR mutations in female. This slide summarizes the follow-up duration, Osimertinib exposure, and the discontinuation causes. The higher median follow-up and duration of taking Osimertinib was long in FLORA, FLORA2, and our trial, reflecting longer benefit in the first-line Osimertinib use. Osimertinib was used in first-line in our trial, FLORA and FLORA2, but it was used as second-line in the AURA3 trial. And disease progression remained the most common cause across all the studies for discontinuation of treatment. Here is the Kaplan-Meier curve for the progression-free survival in our trial. The median PFS in our study was 20 months. This result is very close to FLORA and FLORA2, suggesting the comparable efficacy even with the generic Osimertinib. The higher PFS in our trial flora and flora 2 reflects better outcomes in the first-line osimertinib use in the metastatic lung cancer. The median overall survival in our trial was 24.6 months. While this is lower than the flora and flora 2, but it remains comparable with the Aura 3 trial. The overall survival in our trial is lower than flora and flora 2, but similar to Aura 3. We have analyzed the causes of differences in the progression-free survival and overall survival. As you see, there was more advanced disease at baseline in our trial compared to the other 3 trials. All patients in our trial were in stage 4. And the performance status were relatively poorer in our trial. And the delay or interruptions was a little bit higher in our trial. There were some research methodological differences which may be the reason for the low overall survival in our trial compared to flora 2, which may be due to the small sample size, 97 versus 279 in flora and 278 in the flora 2. Our trial was retrospective, so there was some information bias, missing data and confounding factors issues. And there was some treatment setting issue, like the first line in our trial, flora and flora 2, but second line in the Aura 3. Median follow-up time was shorter in our trial, that is 21 months, versus flora 35.8 months, flora 2 48 months, and Aura 3. There were some resource availability issues like lack of stricter monitoring, lack of resources, healthcare system factors like limited access to advanced diagnostic and supportive care treatment, and socioeconomic factors. In terms of progression-free survival, local brand osimertinib is as effective as research brand Tagrisso in flora and flora 2. Although overall survival is lower in our study compared to flora and flora 2, but we hope that with a larger sample size and longer follow-up time, the overall survival of the local brand osimertinib will be similar as the research brand Tagrisso. Thank you.
Thank you, Dr. Towhidul Islam. So this time the topic